Okay, our topic now is otitis media. And actually, much as I adore Rick, the publication that we're going to discuss is 25 pages long. The critique of the publication that we're going to discuss is 15. So, sorry, Rick. You ranted, but it's okay. We're to talk about the new guidelines that came out about otitis media. These were published by both the pediatrics folks and the family medicine folks simultaneously. And it was supposed to be this groundbreaking, free us from the tethers of having to give antibiotics publication. It was going to get us all on the same page. We were going to diagnose this thing accurately, treat pain well, focus on the groups that really need to be treated. This thing is absolutely impossible to use. How many of you have read it? Oh, God bless you. But those of you who haven't, you're fine. And by the way, there's a Reader's Digest condensed version. If you go to the website, they have a little 2-page thingy that kind of summarizes it for you if you prefer that from the 25-page thingy that's in there as well. What I will do over the next half hour is walk you through it so that you know what's out there. But I think as we walk through it together, you're going to see why it's kind of hard to use and why a lot of people read it and discarded it right away. So we'll kind of get into that. The scope of this is enormous. Okay, the scope of the otitis media issue is absolutely huge. There are 25 million visits to healthcare for otitis media. And if you show up seeing a physician or a family or a PA or whoever with otitis media as your discharge diagnosis, 8 out of 10 times you're going to walk out with a prescription. Okay, 8 out of 10 times. For every 809, there are 809 prescriptions for every 1,000 visits. 13 million prescriptions a year for otitis media. The cost ranges from $10 to $100 per prescription. We're dealing with a huge amount of money. Minimum of $130 million cost just in antibiotics. $1.3 billion in this if we end up really adding it all up at its worst case scenario. Huge impact, absolutely enormous impact. 80% of kids, however, if you don't give them antibiotics and you just let them stew, will get better. So only 1 in 5 kids actually gets any benefit from the antibiotics themselves. 80% of kids clear this infection all by themselves. And the milieu now is a little different than it was back when because every kid now is immunized for almost everything out there that's potentially lethal. You know, now pediatrics these days, there's really not a lot to treat anymore. Get a leukemic every once in a while and somebody with congenital heart disease and the rest of it, kids do really well. I'll tell you, the people who save lives out there are not us so much. It's those nerds that we went to school with that went and became vaccine developers. And they had a whole heck of a lot more impact on saving people's lives than you and I ever will. It's been a huge change. I've seen it. Those of us that are a little gray around the temples, you know, the change in our practice is enormous on what's happened in the post-vaccine era. It's absolutely incredible. It impacts otitis media as well, and the otitis media focus has been, people have made their whole careers academically based on studying otitis media. There are so many papers out there, it's kind of mind-boggling on an entity that honestly is probably overblown and definitely overtreated. So let's get into this a little bit. Did you know, by the way, I love this quote, for every preschooler, on average of their body weight, 5% of it is bacteria. 1 to 2 pounds per toddler of bacteria. Who figured that out? That's actually in this publication. It's in there. I found it's 1 to 2 pounds. My nieces are carrying around 1 to 2 pounds of bacteria in their bodies. It's kind of amazing. I think it's kind of amazing. Okay, let's talk about what the recommendations did. So I'll give you sort of the quick overview, and then we'll get into a little bit of detail. The first thing they focus on is, first of all, let's make the accurate diagnosis of acute otitis media, which is a different entity from basically a middle ear effusion. Okay, fluid behind the eardrum means nothing, just in and of itself. We have to all get on the same page with diagnosing acute otitis media. What these recommendations say is you have to have basically 3 things to be acute otitis media for us all to try to diagnose this the same way. First is recent abrupt onset of signs and symptoms of inflammation with a middle ear infection. So a fever, pain, and some fluid behind the eardrum. Okay, that's the first piece, but that's not the only piece. The next piece is to actually confirm that middle ear effusion by something like, seeing bulging of the eardrum, using your little squeezer thing, which most of us have to, find. It's somewhere on the floor, or in your pocket, or in the backseat of your car. You may see an air fluid level behind the drum, or actually drainage from the ear. So prove there's fluid behind the drum, okay, and they have to have acute symptoms. In addition to that, they have to have signs of inflammation as well. So either the drum has to be red, or they have to have a whole lot of pain. So it has to happen quickly. There has to be proven fluid behind the drum, either from draining out of the ear, or air fluid level, or it doesn't move, or it bulges. And then they have to have either pain or some other sign of inflammation, red eardrum, fever. Okay, those are the things that they have to have. So then the point of that was to try to not have us treat just the kid with a cold who happens to have a little fluid behind the drum, but the ear doesn't hurt. There's no bulging of the drum. It's not red. There's just some fluid back there. So it's trying to get us all on the same page. A valiant effort, and there's a whole bunch of sort of criticism of this that Rick gets into in his chapter here, because it is the criteria for diagnosing this are a little bit wifty, but at least it gives us something we can practically do. It doesn't ask us to do tympanometry, which most of us don't do. It doesn't ask us to suck juice out of there, which none of us do. It basically gives us a clinical way for all of us to diagnose this the same. So that's point number one they make in these guidelines, and reasonable. I think that's okay. Point number two is that you should assess and treat pain. Okay, if they have pain, pardon me, you should assess and treat it. And they have a whole little chart in here basically saying, give Tylenol or ibuprofen, which is smart to do. You can use local anesthetics as well. The problem is they don't last terribly long. The parents always love that. The kid's screaming, you put in the Aralgan, they're happy, they rip apart the emergency department, they throw the 4x4s all over the place and pull your stethoscope. You examine them, life is beautiful, and the parents say, can I have some of those drops? Can I just get, and actually our Aralgan drops are the most common thing that disappears meds-wise from our room. If you walk out, the bottle's gone. Where did it go? It's actually, so treat the pain, either locally, but that doesn't work long-term. So give something orally to work more long-term. And they say address and treat pain, and I think most of us pretty much do that. Now we get into the dicey part. They get into this sort of who needs antibiotics and why, and can you get a subset of kids that you do not have to give antibiotics to. Okay, now this guideline focuses on the 6 month to 12-year-old. So they basically focus on that. So what they basically say here, we'll get into some distinctions, is they say there's a subgroup that can get OBS. I'll tell you about that in a second. The key to that, though, is the parents need to understand what the observation things they're supposed to be looking at and when to bring the kid back. They also have to have transport back to you. So they basically give this caveat of there will be a subset we'll tell you about here in a second that you can just observe, but if they don't have transportation, or if you're worried that the caregiver doesn't understand you, forget it. You give antibiotics. So they've defined a subset, I'll tell you about in a minute, that they give you leeway to not treat, but then they kind of undermine it a little bit by saying if they don't totally get it, they can't get back to you, and they're not going to observe them well, then just treat them up front. And I'll give you the subsets in a second. They say if you do give antibiotics, and we'll talk about which categories of kids they're recommending antibiotics for, they recommend high-dose Amox as the drug to choose. 80 to 90 milligrams per kilogram per day. Big doses. Okay, this is the double dose Amox versus the old days we used to use 40 per kilo. This is 80 to 90 per kilo per day. Divided TID dosing. 10 days for one category of kids and 5 days for another category. So we're already getting complicated here, right? I have a group I can not give antibiotics to and observe if this, that, or the other thing. I need to give amoxicillin in the group I'm going to treat, but there's going to be a subgroup they want me to give it for 10 days and a subgroup they want me to give it for 5. I'm already getting confused here. Okay, this is just the general categories without even defining them yet. Yeah?
A quick side note, on the MRSA, you use double-strength Bactrim as well.
Yes.
Two double-strength Bactrim twice a day?
No, we're not, actually. We're doing 1 double strength twice a day, not 2 double strength. We haven't doubled the dose for that yet. We'll see. The next step in the antibiotics thing, and again, I'm going to come back to this to define it a little better for you, is say they don't respond to the antibiotics, they come back still sick, or you observed them the first time around, and now they come back sick. Now they recommend kicking in antibiotics if it was OBS group, or changing antibiotics if it was the Amox group. The antibiotics they recommend changing to are either Augmentin or ceftriaxone. Okay, Augmentin orally, ceftriaxone IM is what they recommend for the, quote, failures of initial antibiotic treatment. I'll come back to the definitions of all this in a second. They also, at the sort of 0.5 of their recommendations, just giving you this Reader's Digest condensed version, they recommend preventing recurrences and doing things like keeping the kid away from smokers. Good luck. Bottle propping is not a good idea. No pacifiers, and recommending breastfeeding, which do all decrease the risk of otitis media. So some of this stuff makes sense. You know, don't use a pacifier or prop a bottle if kids get recurrent otitis. That makes total sense. Keep them away from smokers if you can. Treat their pain. Get the diagnosis on, you know, we're all making the same kind of diagnosis. The harder part comes down to, though, who gets antibiotics. Now, what I'd hoped they would do with this publication is really focus on the fact that the 80% of kids without treatment get better, and how we can get to the 80% rather than over-treat as much as we do. The resistance that we talked about, MRSA, things like MRSA resistance issues come up because we use antibiotics like water. Rick calls it sheep dipping. And we take kids and we sheep dip them in antibiotics from birth every time they get a fever until they're about 6. You just dip them every time they get some sort of fever. We clearly are contributing to the resistance issue. What I'd hoped they would have done with this is like they've done in Europe, which they've really downplayed antibiotics in Europe overall. They hardly ever use them, and they use a lot of tactics to make families happy, but they hardly ever use them. For instance, in the Netherlands, they've dropped their resistance rate to virtually 0 for things like doxycycline. You know, stuff that we can actually still use now, but they can use the other beta-lactams, the penicillin-type drugs, because they don't use them anymore. So now it really works when you do use it. I was kind of hoping they'd do that for this. They didn't. Okay, let's go back now, because if they say there's a group I can OBS, officially with the sanction of the family medicine and peds people, who are they? And which ones do I need to treat aggressively and which ones not? Which ones do I need to use augmentin, et cetera? So let's go back. Now again, we're diagnosing it by acute onset of symptoms, fluid absolutely behind the drum with evidence of inflammation, either pain or redness, fever. Okay, so we're all looking at the same kid. What they do to recommend antibiotic treatment is they divide kids into subgroups. This is why I find guidelines like this a total pain in the neck. What they do is divide them by age. They divide them into 3 groups: less than 6 months, 6 months to 2 years, and 2 years and greater. Okay, 2 to 12 years. So those are the 3 groups. So if we're looking at a 5-month-old, we all say, yep, that's otitis. There's kid's newly crying, the eardrum is bulging, it's red, there's fluid. Cool, it's otitis. We've all kind of agreed on that. They say any kid under 6 months of age gets treated, period. So that makes, at least as far as the guidelines, if you want to follow them, that group is easy. Every kid gets treated. Even if you look in there and you're like, I think there's fluid, the kid is crying, maybe it's a little red, I'm not 100% sure of this, I'm not completely certain of my diagnosis, but I'm suspicious, they even tell you to treat that group. So they kind of even contradict themselves in the beginning here. So, they wanted to get us all on the same page, but they give you a little bit of wiggle room on this with this. I'm not exactly certain of the diagnosis. Now, let's go, okay, that's fine. So under 6 months, basically, they've given you carte blanche to do what you've been doing forever, which is to give the prescription. Yeah?
The reason for that recommendation is they're at higher risk for complications, hearing loss, and what's the rationale?
Theoretically, no, I'll tell you, you know what you get from antibiotics? You don't get decreased complications. You don't get decreased hearing loss. You don't even get decreased mastoiditis anymore. What you get is 1 day less of crying, which for any parent in the room, that's worth a lot of money. You get 1 day less of crying. You get less analgesic use, but on pain scales, it's no different. And basically, that's about it. For that, you get a 10 to 15% increased risk of diarrhea. Crying, diarrhea. You don't get a lot for the antibiotics. Usually 1 day less of symptoms is what you get. The complication rate, and part of this is in a milieu of overuse of antibiotics. If we stopped using antibiotics tomorrow entirely for otitis media and let it cook as a natural history disease for the next 2 or 3 years, I don't know what we would see. Back in the old days, you did have hearing loss and lots of eardrum perforations and hearing loss issues. And mastoiditis did occur. However, in the Netherlands, where they stopped using antibiotics for this, their mastoiditis rate didn't go up at all. And they didn't have significant problems with deafness in kids either. So I'm not sure what the natural history is anymore, but I know what you get right now is 1 day less of crying and less analgesic use by giving antibiotics, so regardless of age. And by the way, if you want to get into this 25-page doodad, if you want to get into all the details, it's all there. All the references are there. Have at it. It's painful. Just painful. Unless you really want to go to sleep and you're having trouble with insomnia. Don't. Okay, so that's less than 6 months. If you want to take the simplistic approaches, kind of think it's there, or I'm sure it's there, I give antibiotics either way. What if it is a 13-month-old? So I've got the 6-month to 2-year-old group. How do I approach antibiotic use in that group? Well, this is where they give you the observation possibility. But let me tell you how they define this. And this is where this just is so irritating. They basically say, if it's 6 months to 2 years of age, you're absolutely certain it's otitis media. Acute onset pain, bulging eardrum, fluid behind the drum, treat. That's it. They say treat. If you are uncertain of the diagnosis, maybe it is, maybe it isn't, and they are non-severe in presentation, defined as mild ear pain and a fever of less than 39 degrees. So they're already making this impossible to use. Okay, the kid's 13 months, it puts me over here. I'm not totally sure of the diagnosis. Okay, it puts me over here. Their temperature is 38.2 and they have a little bit of pain. Oh, well, the guidelines say I can observe that group. I mean, how complicated is this? If it's that kid, okay, they're 13 months, I'm not sure it's otitis media, but their temperature is 39.1, they want me to treat. Or 13 months, I'm not really sure their ear is red, but goodness, they're having a whole lot of ear pain. Treat. If you really look at where these recommendations came from, it's WIFTY science. And it tends to be, I've found this in a lot of the PEDS recommendations, they are very conservative in what they recommend, be it head trauma, be it bronchiolitis treatment, or you name it. They're very conservative in what they recommend for this very healthy group of patients in general. They're bounced back quite well. They've made this very difficult to use, but they do give you this little, okay, here's a subgroup where you're okay to OBS them only, bring them back in 48 hours and check them out, but you can OBS this group. So they give you some sort of freedom to do that if you want to follow these guidelines. I have to, we'll take a poll at the end what you think. But that's the deal. If they're 2 years or greater, so 2 to 12, so it's a 5-year-old who comes in with, wakes up in the middle of the night crying with ear pain. You look in there, it's a big, gnarly, bulging ear with fluid. I mean, we've all seen gazillions of these kids. They may or may not even have a fever. You see that kid. What do they say? They say, well, if the kid's really severe, lots and lots of pain, high fever, treat them. Again, not based in a lot of literature on that. But if the kid isn't severe, okay, they come in and their ear isn't that painful. Yeah, it's bulging. Yeah, they had pain that came on suddenly, but it's not a lot of pain. They're not that febrile. You can OBS that kid. Okay? And the other group you can OBS is it's a 5-year-old who says their ear hurts a little bit, but I look in there, it's not much. They said OBS that one as well. So your OBS groups, by definition, according to this guideline, is 6 months to 2 years. You're not sure of the diagnosis, and they're not very sick. Not a lot of pain, not a lot of fever. Or they're over 2 years of age, you are sure of the diagnosis, but they're not very sick, or you're not sure of the diagnosis. Those are the groups that they let you OBS. And again, the OBS is predicated upon being able to get back to see you if something changes and knowing what to look for. Do they spike a fever? Does the pain persist for 2 days? And seeing them again 2 days from now. Okay, when you see them again 2 days from now, whether you gave them antibiotics or not, you fall into that next category. They come back 2 days later. If you've OBS them and they still are sick, now they recommend giving antibiotics, Amox. If you gave antibiotics up front and they come back still sick at 48 hours, they recommend switching to Augmentin or ceftriaxone. And I mentioned earlier, we have one more little thing to throw in there just to make this a little more complicated, is how long do you treat? One quick second, then I'll sort of throw it out there. They recommend a 10-day course if the kid is less than 6 years of age and has severe symptoms. They recommend a 5-day course if the kid is 6 years of age or greater and mild symptoms. I mean, oh my goodness, is this impossible to use? I mean, honestly, yeah.
Yeah, for us that work in a busy ER, and the reason a lot of times they're there is they don't have a primary care, can't get in for 2 weeks. How are these recommendations really helping us in the ER, since that you don't want them back in your ER for another 6 to 8 hour wait? They can't get in their HMOs for 2 weeks.
Right.
Where does it really play into reality?
Well, it doesn't. And the thing about guidelines overall, and some of them are very good. I don't want to diss guidelines in general, but the thing about guidelines is they're often formed in a little room with a bunch of papers that have been published in a group of people that rate the papers and come to some conclusion that may or may not be based in what is practical out there. This, for us, is very difficult to use. And if you're going to try to ob somebody, they say bring them back or have them re-seen within 48 hours. It doesn't happen. And actually, just separate from the guidelines themselves, if you get into just the medical practice and literature looking at things like delayed antibiotics just in general, you find that if you give delayed antibiotics, however you do it, date the prescription 2 days from now, tell them to put it in their purse and take it out if they're still symptomatic, whatever. However you decide to do delayed, that actually anywhere between 50 and 70% of families never fill the prescription because they don't need it. And these are kids that aren't followed up 2 days later. They do fine. So this is that super conservative approach to pediatric care that to me is a bit of a mystery. I'm not exactly sure. It's not practical. And I think they're just super conservative because that's kind of what they do. Yeah?
I was about to say the same thing because in a reality situation, that's what something might do. I tell the parents, if you educate them, and they say, I'll write the prescription antibiotic, and if he spikes a fever in 2 days or pulling up ear or get more irritable, then fill it, but most of the time this will stop.
Right, and in the meantime, you tell them to give good pain medicine.
Yeah.
Give something, because often they come in never having treated the fever or the pain, because they don't want to give anything to the kid, whatever. So that as well, and that works beautifully. What do you guys do? Yeah, go ahead.
The other caveat is that if you don't spend the time educating them,
Oh, yeah.
then you've got them going to the pediatrician and saying, well, you've got an ear infection, and then they think you didn't diagnose
Oh,
them.
yeah. That's for those of us that work in the ED, I make a plea to those of you who work in an office that see these kids in follow-up, or anybody we send out in follow-up, please don't say, they didn't give you antibiotics? What could they have been thinking? It happens all the time. And we actually had a big brouhaha at the place where I used to moonlight about 8 years ago on this topic because we had a pediatric group that basically kept dissing the ER to the point of complaints and threats of suits and, just the annoyances. Nobody's going to sue for otitis. But it was just stuff that we just didn't need. And we had a powwow and say, look, this diagnosis is whiffy at best. We all know that there's issues with this. Don't diss us if we decide that that day we don't treat. Who knows what you see 2 days later if it's the same or not? And who knows that you're right? So you have to be careful with this. You're absolutely right. And educating and talking to the family is probably the most important thing you can do in this. Yeah?
In the January 2004 abstracts, Jerry and Rick did a paper looking at using the recommendations to treat with high-dose amoxicillin versus not using the high-dose amoxicillin.
It's actually in here.
And it is.
It's in there.
Okay. I'm sorry.
No, it's okay. No, please finish.
And and the point was they made 2 points. The first was that the high dose had no benefit over the regular dose, and the second was, and these were Rick's exact words, treating anyone for 10 days with anything is cruel and unusual punishment. That's true,
especially something that causes diarrhea. So fill your prescription and buy more Pampers. And yeah. What do you guys do with this sort of thing? Does anyone, and God bless you if you do, you're fine, but does anyone follow these things to a T? I don't know a pediatrician who follows these things to a T. Even our ER pediatrics gurus who are super conservative where I work, it drives me, I stopped attending on the ped side separately because it drove me nuts. They were so conservative, I couldn't stand it. Our peds people don't follow these either. So I think the problem with guidelines like this is they're out there. I don't think any of us follow them, do them. What do you guys do instead? What's your practice? What do you guys approach?
Don't use antibiotics, educate the parents, and ensure follow-up in 2 days.
So yours is a low-ball approach just in general. As long as the kid's not septic looking or gnarly looking, or if it's just an otitis, you just send them out.
Right.
Do you send them out with antibiotic prescriptions at all?
No.
Okay. What do you do?
Slightly different conclusion from this whole thing. It's not necessarily whether you treat real otitis media with antibiotics, but you do not misdiagnose or overdiagnose. And I think that's what the problem is. And I just had a situation where I work on a literal island that it's a tourist, has an attraction of tourists.
Sounds good.
So we have a local pediatric practice, which is very good. They educate their parents. They don't misdiagnose otitis media. They don't overuse antibiotics. And as soon as we have a school vacation, we get an influx of suburbanite, from the New York area, and mothers come in with a kid that has a cold, and it just says, every time my child has a cold, he has an ear infection, has to be on antibiotics, and you know that it's been way overdiagnosed and misdiagnosed and overtreated.
Absolutely.
And if that problem ever goes away, I think the problem will go away.
Well, I think that's part of it.
And
I agree with that entirely. I agree with that entirely. And that's why the first point of this particular paper, which is probably the most important point of this at all, is accurately make the diagnosis. For those of us that work in almost any medical setting, but the ED for sure, the kids come in, see you, and lose it, and have been shrieking for 20 minutes by the time you get in there. And of course their ears are red, and it makes it a very easy default diagnosis if you want to wimp out. But the reality is it often isn't otitis, and it just takes a little bit of education. Even those suburbanite parents sometimes, especially if you tell them, you know, it doesn't really help, and you have a 10 to 15% risk of lots and lots of pamper changes because they're going to get diarrhea. And it's actually, have you seen a trend? I've actually, for the first time in my career, started to see a change in what parents are. Parents seem to be getting it.
But I think it's the doctor's fault. That's what I'm saying. Like, you know, now new parents are aware that like viruses aren't cured by antibiotics. But there are a lot of doctors that really miseducate the parents, or the parents of a certain type that then fall into that practice.
Right.
Which, and I don't know how that's ever going to.
If they walk into the ER with their own plastic surgeon, I usually just write the prescription. It's like, you're going to want them, here you're going to have them. It's not worth getting in a fight over on this stuff, but it is absolutely worth making the educational effort. One of our local ERs has, the CDC has really cool publications, patient education publications. Hit the CDC website. You can actually order brochures on certain things, one of which is Approach to Otitis Media and the Downside of Overuse of Antibiotics. That is a fabulous, easy to read, throw it out in your waiting room or your emergency department waiting room for them to read. It's wonderful. And they come in saying, oh, I didn't know it wasn't going to work and that there were all these side effects. I don't want to do that to my kid. So it's actually a very proactive educational thing to do as well as your own education. Yeah?
Well, believe it or not, I've done 28 years of emergency medicine only at night.
God bless you. You want to come work at my place?
At 3 o'clock in the morning, patient education, you can throw it out the window. I've done the pamphlets. I've sat down with patients. It just does not fly.
Well, part of it is what yeah. Right. I mean, you know that part of it is they're fried. If the kid's been crying since dinner time, they need to go to work in 3 hours, and it's like, okay, just do something. And I agree it's frustrating at 3 in the morning, and I'm not at my best at 3 in the morning, especially as I get older. But I think it still is worth the effort, and I know it's frustrating, but I find Aralgan is magic. The crying goes away. I tell them that if they give their kid pain meds at home, it will stay away. The antibiotics aren't going to necessarily make that go away any better. And if they really push me, I have to tell them the truth, which is antibiotics will take away a day of crying. And they're like, give it to me. You know, I want it now. I think it's still worth the effort, although night shifts are particularly hard because the milieu is just different. If they're there at 3 in the morning, it's not good. You know, everybody's wiped out and tired. Yeah?
On your secondary treatments, the Roseceptin, how long and how much?
Oh, yeah, they don't really quite get into that. Oh, well, you know. They basically are recommending, if they fail the outpatient treatment, it's a 10-day course. So it's basically they're recommending IM for 10 days. And that's just not particularly useful. So, yeah. So, anyway, I'm going to break it because I'm going to bring in Al. But overall, this is the general gist. I think you stick with your own practice. You know, your own practice is probably just fine. You know, we don't have kids dropping dead of otitis media, you know, on every corner. So I think we're doing just fine overall on this. And this is a valiant effort, but incredibly disappointing as far as our ability to use this. It's kind of a drag. So, all right, let me go.